So I am going to focus on using ABA to improve older adult brain health. So just very briefly, Bergio and Bergio back in the 1980s published the seminal paper on behavioural gerontology. And within this paper, they identified that behavioural gerontology, that ABA was a really relevant application for older adults, the health and any of the issues associated with ageing or getting older. Within this paper as well, they identified, or they really envisioned the field of ABA being huge with ageing. So they saw this field of behavioral gerontology, that it was going to become huge, really important, and a big focus of behaviour analysis. Now, since then, there have been some special issues on ageing that have been published in the major behavioural journals, but really this focus or the popularity of behavioural gerontology that Bergio and Bergio would have envisioned hasn't really come to fruition. The field is advancing, so there are, obviously plenty of publications in behaviour analysis for ageing, but not all the time by behaviour analysts or in behavioural journals. So we would see, for example, the work of Susan Nishi in health behaviour. That's a lot of aspects of that we would think would be quite similar to the work that we would do, but she's a health psychologist. Or, sometimes behaviour analysts might have to adapt their terminology to have publications accepted in other journals, like cognitive journals. So that's, something that I would have experienced myself also. And so really, I suppose, there's a real gap here. There's a gap where there are so many applications of ABA for older adults. But I think as behaviour analysts, we need to identify what these are and start thinking in different ways when we're thinking about how we can apply our skills in different areas. A review of behavioural gerontology trends identified a great disparity between the numbers of publications that are focused on intellectual and developmental disabilities, for example, and then those published in ageing. So in one review, Buchanan identified across a 25-year period, only 109 publications were related to ageing across 8 behaviour analysis journals. So if you think about that, 109 in 25 years, and then think about maybe how many of these ABA publications would have been focused on developmental or intellectual disabilities or autism and so on. So there is a great disparity. Of the research that's published in these behavioural journals on behavioural gerontology, the focus is predominantly on dementia populations and then predominantly on the behavioural and psychological symptoms of dementia within those populations. Typically, research is conducted in care settings and very rarely focused on these kind of health-focused or lifestyle interventions to improve brain health. So the ageing population then, I just want to identify the relevance of why we should be able to, or why we should be looking at focusing our skills on the ageing population. So improved healthcare and healthier lifestyles means that we're all living longer. So across the world, all over the world, we're seeing or experiencing population aging, which is really positive. And really what that just means is that people are living longer. So obviously this is very positive. And there are a number of contributions to that. And one of them is modern medicine. So obviously modern medicine has made a huge contribution to our ability to live longer. This quote, "The global increase in life expectancy is the single most impressive achievement of modern medicine." And, the UAE was actually identified as one of the key examples of this. As well as that, then, I suppose worldwide, levels of education are increasing around how to just live healthier lifestyles. And that's making a huge contribution to life expectancy also. With longer life, however, does come some challenges. So we would, some challenges for older adults as we get older would be in things like a reduction in functional independence. So some people who get older might have difficulty with mobility, for example, or they might have difficulty in activities of daily living, so just helping themselves get through their day. And these can be associated with the part of our brain responsible for executive functioning. So our executive functions is the part of our brain that helps us to plan and organise and really helps us to navigate our day. As well as a reduction in functional independence. With longer life comes greater risk for the development of cognitive decline and the development of dementia. You can see here on the graph on the right-hand side of your screen, this is the projected rise in global dementia rate. And this comes from the Alzheimer's Disease International. The projections do vary depending on the source that you read it in, but across the board, the increases are common across the board. So everybody is projecting an increase in the numbers of people who will experience dementia. So really, both as a society and as behaviour analysts, it's important for us to think about and to understand how we can care for our ageing population. What is it that we can do? You know, obviously we're all going to get older, so it's something that's applicable to ourselves, but also just from a population point of view and a societal point of view. How can we contribute to improving outcomes and quality of life for older people within our society? So when I talk about dementia, often I get the question that people want to learn the difference. What's the difference between Alzheimer's disease and dementia? So dementia is, if you think about it like an umbrella term, where dementia describes the sort of symptoms of the disease or describes the range of conditions that cause damage to the brain. Alzheimer's disease is the most common cause or the most common form of dementia. So if you think about when I say dementia, I'm talking about all kinds of dementia and Alzheimer's. So when I say dementia, I am incorporating vascular dementia, frontotemporal dementia, Alzheimer's disease, Korsakoff syndrome. So all of these are under that umbrella of dementia. Okay, so let's get to the point of the presentation then. So what I really wanted to talk to people about today is thinking about interventions to prevent dementia potentially and interventions at each stage of dementia. So starting with the first topic that I want to talk about. So this is really focusing on this idea of brain health and dementia prevention. So, you know, dementia prevention, I want people to think about this in terms of risk reduction, okay? And if we can compare this, if I can compare this to another area, it could be comparable to, for example, cancer research. So we know that there are things that we can do to reduce our risk of lung cancer, for example. So if we stop smoking, we're going to reduce our risk of lung cancer. So we understand that some cancers are preventable, and it's the same idea with dementia. So some dementias are preventable by changing our lifestyle behaviours. Now that said, that doesn't mean a person could still do everything right and still end up with the diagnosis of dementia. So, you know, we would all have know somebody and we would say, oh, this person never smoked a day in their lives and they still developed lung cancer. Kind of the same idea with dementia. So when we're talking about dementia prevention, we're thinking about this from a population perspective and looking at factors that can prevent dementia from a population point of view, okay? So there's years of epidemiological research provides a substantial amount of evidence that there are modifiable risk and protective factors that can be addressed to prevent or delay the onset of dementia. And this dementia prevention research has been going on for years now. So as far back as 2011, Barnes and Yap identified these 7 risk factors. And they identified that a 10 to 25% reduction in these risk factors could potentially prevent as many as between 1 and 3 million cases of dementia worldwide. So there's been a lot of work done in the last number of years on this idea of risk and protective factors. A lot of the research on dementia prevention has been published in the Lancet journal, so Lancet Neurology, and a number of other Lancet journals. In 2020, just very recently actually, the Lancet has published an updated report, and they identified now there are known to be 12 risk factors that account for around 40% of worldwide dementias. So these are the targets that I want us to think about, okay? So these risk factors and protective factors are the targets for improving brain health. Brain health in turn can delay the onset, and in turn, by delaying onset, dementias can be prevented. Just to explain that in a little bit more detail. So one of the greatest risk factors for dementia is age. So the older we get, the risk is increasing, okay? If, let's say, for example, an individual would have maybe been diagnosed with dementia at age 80. If the delay of that dementia, if you could delay the onset of that dementia for 20 years, it's likely that the individual would never need to experience that dementia within their lifetime, okay? So it's all about delaying onset for as long as possible, and if you delay the onset for as long as possible, some people may happily live out their lives without ever having to experience the onset of that dementia. So I hope that makes sense as well. It's really about brain health, delaying onset, and that delayed onset in turn will lead to prevention. So there's a couple of publications just to point you to, or a couple of areas. I have resources at the end as well, but the 2017 Lancet Commission on Dementia Prevention and the European Dementia Prevention Initiative has been doing great work in this area and have been looking at developing randomized controlled trials that test these modifiable lifestyle factors. I mentioned there were 12 factors currently, but these are the 9 most common factors that are discussed in the research. So these are the risk factors. So depression, lifelong depression, diabetes, smoking, hypertension, and less education. And I put an asterisk beside that less education because I wanted to just remind myself that less education is relevant up to the age of 20. So this is again another reason why we need to consider dementia prevention from a life course point of view. So education is very important in the dementia prevention story, and education up to the age of 20 is key. And then after the age of 20, it's more about maybe occupational attainment or how much mental stimulation or cognitive stimulation you get across your lifespan after you've gotten your, let's say, your education up to the age of 20. Obesity or a poor diet is another risk factor, physical inactivity, low social contact, and hearing impairment. These are all risk factors. Of those, the last 5, so education, diet, physical activity, socialization, and hearing impairment, my colleagues and I have published systematic reviews and meta-analysis on those 5. So just the references are at the end in case anybody did want to catch up on those. So looking at these modifiable lifestyle factors, a number of randomized controlled trials have been developed. So for people that aren't familiar, a randomized controlled trial or RCT is the gold standard of intervention research. So they're very well conducted intervention studies that look at whether an intervention is effective. A number of these studies have been published. So the lists are there, the MAP study, the FINGER study, the PREDIVA study. If anybody has ever applied for funding or looked at any kind of a trial, an intervention trial, you know you have to be really good at acronyms. And behaviour analysts are generally quite good at acronyms, so there's another reason why we fit in there. So each of these trials have had, some inconsistent results across trials. So some of them have identified, overall, we would say small, significant group reductions in dementia risk. So group reductions in cognitive decline and dementia risk. But there are issues, okay? What the main issues that have been identified across these trials are intervention adherence and dropout. So the key issues within these really important intervention studies is that people who have been allocated to an intervention group are not sticking to the intervention, and also they're not really motivated to continue in the study and they tend to drop out. And across the board with all of these studies, these are the 2 key issues that have been identified. So what this means is, well, we can't really determine whether the intervention is effective because people are not really doing it or engaging with it as we would hope. So to take a couple of quotes from some of those research studies, one big study with preventative therapy in general is motivating people to take action. Well, how do we get people to comply with a treatment when they were not going to see benefit for a number of years? And this problem of low intervention use and high dropout rates continues to pose difficulty. So who do we know? So the behaviour analysts out there, who do we know that could arrange contingencies to increase motivation? Who do we know that could look at improving treatment compliance or intervention adherence? So I'm sure you all see where I'm going with this now. Behaviour analysts are very uniquely placed to be able to work with these kinds of intervention studies to try to improve intervention adherence and to try to reduce dropout rates. Interestingly, of these studies, one of these studies was the Hathaway study. And this intervention included things like goal-setting behaviour, problem-solving, positive reinforcement, and self-monitoring, and then monitoring by others. And this is one of the studies that found the most positive results because more people were adhering to the intervention. And what they did say was that using fewer but more effective behaviour change techniques could increase intervention effectiveness even more. So, you know, this is important. This is the contribution that we as behaviour analysts can make to dementia prevention. This is how we can and need to work in the dementia prevention space. So the evidence is there. It tells us how we can reduce risk or how we can delay or prevent dementia. All of that evidence is there. But the issue is around motivation and intervention adherence. And that's what we do. So, you know, if there's one real takeaway point from today for all of our BCBAs out there, it's that we can, you know, think outside the box and think about how we can apply our skills in different areas that can have a massive, massive social significance. This might not be something that generally as ABA we would consider ourselves doing, especially in the context of healthy aging. But, you know, I want everybody to reconsider that after today. Okay, I'm going to ask people then to have a think about this. So I'm going to open up my chat box and I'm going to have a look at and see what people type in here. So this is all a little bit of cognitive challenge. So I like to practice what I preach, incorporate some cognitive challenges into my talk because it's good for your brain health. So if you have a look at the behavioural targets there, so if you were to work on an intervention and you were going to increase consumption of a healthy diet, or increase engagement in physical activity, or improve levels of social interaction. These are all behavioural targets that can contribute to dementia prevention. What are the kinds of behaviour change procedures that behaviour analysts might consider for these? I'm just going to open up my chat box now and see if I can see this. Okay, so body size. Body size and diet are distinctly different concepts. So self-monitoring, yeah. Shaping or DRA, yeah. Sounds like some of the ACT brief interventions. Yes, absolutely. So I'm not sure I think that was Sarah that said that about ACT. So there's already some fantastic work being done in the ACT space. So both acceptance and commitment therapy and acceptance and commitment training. Some really interesting work has been done in that, looking at increasing physical activity and a healthy diet. So yeah, that's a really good point. Decreased response effort, that is actually a really good point as well. That was Clodagh. Yeah, decreasing response effort is probably a big part of these interventions. Absolutely for social engagement and even for physical activity. Like we need to think about the sample. So it's older adults. So, you know, you're not going to encourage them to be going out running marathons. So adapting the activities in a way that decreases the response effort would be a really good idea. Group contingencies, absolutely, Devon. Yeah, that's something that was worked into that HATICE intervention and it worked really well. And then the group contingencies also adds in that aspect of social support, even if you're talking about the med diet or physical activity. Shaping, yeah, med diet, teach how to cook these recipes. Yeah, absolutely, that's a good point as well. So actually showing people point by point how to do it. There's no point in saying, eat a Mediterranean diet. Like, what does that even mean? Behavioural contract, yeah, perfect. Behavioural skills training, absolutely. Had a good diet with an open day, yeah. Differential reinforcement. This is brilliant. All of these suggestions are brilliant. So the use of a changing criterion design, yeah, brilliant, and achievable goal setting. So who's that, Baby Linda? Thank you, because that's really considering what kind of behavioural design we could use. So if we were to design this study, how do we determine whether there was a causal relationship between the intervention and the outcome? So what kind of designs can we use? Yeah, goal setting, acting token economy, yeah. Group contingencies and shaping and reinforcement using fitness apps. Actually, that's I think that was Tara. Yeah, so physical activity using those fitness apps, Tara, does actually work quite well. And some of those were incorporated into some of the interventions, and they saw quite positive results as well. And then Farhan, token economy as well. Yeah, so all of those suggestions, I mean, look at, what was that, like less than a minute? Within 60 seconds, we have the issues associated with those prior issues associated with those interventions. We have them all sorted. We're like, we already know how to fix all this. Yeah, behavioural contracts, BST shaping. Oh, that's brilliant, actually. Yeah, thanks for that. Thanks for that, Michelle, putting all of the strategies suggested in together. That's really helpful. So thanks to everybody for your engagement with that. You know, I think that does show that it doesn't take a lot for us to be able to think about how we can apply our skills in a unique way. Okay, so moving on to the next slide then. So around this, I did want to talk to you a little bit about this unique approach to cognitive training that I'm working on at the moment. This is not specific to dementia prevention, but cognitive training programs have been shown to, well, specifically around some cognitive training programs and around increasing mental stimulation in later life, have been shown to contribute to cognitive reserve. So very briefly, cognitive reserve is building up new networks in our brain. And if we can build up as many new networks as possible in our brain throughout our lives, if then at a point, if we start to experience cognitive decline, well, we've got some reserve capacity to help us to compensate for any loss if we do start to experience decline. So cognitive reserve, we want to try to build that up throughout our lives, and having as much engagement, whether it's social engagement, cognitive engagement, physical engagement, that can be really helpful to build up this idea of cognitive reserve. So for those of you who are behaviour analysts on the call, this will be relevant. For people who are not, feel free to have a little nap for this, because relational frame theory does kind of delve into some of the more theoretical stuff. So have a cup of tea or a nap for a few minutes and come back then in a couple of minutes. Okay, so the idea behind this came from the need to design more effective cognitive training interventions. So myself and my colleagues in 2014 conducted a systematic review of cognitive training and mental stimulation interventions for older adults. So not across a life course. If people started these things at age 50, what would the outcome be? We found that training generally can benefit memory and executive functions, but there's not a lot of transfer of intervention effect. So we don't see a lot of generalization. You know, if you train someone in a memory task, they might remember stuff related to that memory task a bit better, but it's not going to translate into an easier life. So it's not going to generalize to activities of daily living. So what I thought was, you know, using my background in relational frame theory, how could we use that kind of behavioural technology to be effective at improving cognition and functioning? One of the things that I noticed when you know, we read about and we write about RFT, typically we will say relational frame theory postulates that relational responding is at the core of human cognition. But not very often do we consider what the core of human cognition, what do we actually mean by that? And I guess thinking about some of my colleagues, my neuroscientist colleagues or my cognitive psychology colleagues, they might say, well, you know, what do you mean by that? And how does what you're talking about from a behavioural point of view map onto what we see from a cognitive point of view? So I published a paper in 2020 try to map these concepts onto each other and looking at the theoretical perspectives of how our verbal abilities from an RFT point of view map onto this core of human cognition. And very briefly, our verbal abilities in RFT are thought to be related to complex repertoires of derived relational responding. So that would be termed relational complexity, and then flexibility in relational responding, so relational flexibility. So when we try to compare these or map these on then to the literature from the cognitive sciences, they map pretty much perfectly onto the concepts of cognitive flexibility and relational knowledge within cognitive science, and these have been identified as core executive functions. So then the idea is that I've outlined in that paper is that, well, if we can design a cognitive training intervention based on relational complexity and relational flexibility, maybe we will be able to target these core executive functions. So just kind of using what we already have in our toolbox as behaviour analysts and trying to apply this in a different way. Some research, actually quite a lot of research, has already been done in the area of complex relational responding and has shown that it can improve IQ scores and math and reading ability. So when we talk about this, we're talking about arbitrarily applicable relational responding, and the acronym is ARING. So research has shown that ARING can improve all of these things, but all of the research has been done with either children or younger adults. The impact on older adults' cognition has not yet been tested or is not yet known. So what reminded me again what ARING is, so I'm just going to keep an eye on the time here because we were a little bit late starting. Okay, so for anybody that needs a quick reminder, you know, you're sort of like, oh, I kind of remember RST from my classes, but I'm not 100% sure. So for a brief reminder of what ARING is. Relational responding, first of all, is just looking at the relationship between two stimuli and responding to or naming or thinking about that relationship. So in this picture here, you could say the man is older than the boy. The boy is smaller than the man. The man's car or the man's bike is slower than the boy's car. So that's what relational responding is. You're just responding to a relationship between two or more stimuli in the environment. When we talk about relationships that are arbitrary or non-arbitrary, so arbitrary means that you're responding to a relationship between stimuli that's not based on any physical properties, okay? So in the first example, if I say the man is bigger than the boy, that's non-arbitrary. That is based on physical properties. So basically, I can physically see that the man is bigger than the boy, okay? In the second picture, in this example, these two are having an argument because he says his computer program is better than hers, and she says, no, my computer program is better than yours. So they're looking at the relationship between two stimuli, and it's better than or worse than. So mine is better than yours. Yours is worse than mine. So this is a relational response, but it's not physical. We can't see better than. We can see bigger than, but we can't physically see better than, okay? So that's what it means by arbitrary. Or I could say, you know, she decides to back down from the argument, so she's the bigger person. She would be deemed the bigger person for stepping down or stepping away from that argument. So, you know, we understand that this is bigger in a moral sense, not in a physical sense. So physically, he's bigger than her. Morally, she's bigger than him. Okay, so this is just what we mean by arbitrary. It's not based on any physical properties. It's less obvious, is another way of saying it. And then derived. So what we mean when we say derived, I like this picture because it really perfectly incorporates what we mean or explains what we mean by derived. As humans, if we're given a certain amount of information, we just know the rest, or we can figure out the rest. And this is what derivation is. So if A equals B and B equals C, then you can do the math. So if A equals B and B equals C, is A equal to or not equal to B? I've opened my chat there, so checking everybody's awake. Is A equal to C? Yes, A is equal to C. Thank you, Clodagh. Yeah, they're all coming in there now. So that's what derivation is. So how did you know that A was equal to C? I never actually explicitly told you, and you didn't get directly reinforced for that. So that's what derivation is. We're able to derive something when given another bit of information. That's essentially what arbitrarily applicable derived relational responding is. So that's it in 3 pictures. Now you understand it perfectly. Okay. So for complexity then, I'm not going to get into the MDML model. Nobody has time for that. But in terms of complexity, a couple of recent papers have talked about increasing complexity in relational responding, and I have those references there just if anybody is interested in looking those up. So my suggestion to behaviour analysts is that what we could do is we could use an existing computer program. There's a couple of different things we could use. We could use the IRAP program, we could use the SMART program or the FAST. My preference is the IRAP, but obviously everybody has their own individual preference. Computer programs like this can be programmed to incorporate cognitive training tasks that increase in terms of relational complexity and that increase in terms of, and that incorporate flexibility. So we can train and assess the flexibility of various patterns of relational responding. So here's one example. I'll give you an example of low, medium, and high levels of complexity. So for low complexity, this could be looking at relationships between stimuli that's non-arbitrary or that's more obvious. This would be like a match to sample task. So match to sample, you're just matching, saying whether something is the same or different or the same or opposite, and it's based on physical properties. This would be relatively low complexity, and most people would be able to do this. But this can be presented in terms of a cognitive training task. This could be medium complexity, so you could move from non-arbitrary to arbitrary coordination relations. This is arbitrary because we understand through learning and through our social conditioning that a half is equal to 50%. But it's arbitrary because it's not obvious or it's not based on any physical properties. It's through our history of learning and through our history of reinforcement that we understand that a half is equal to 50% and that a quarter is different to 50%. So this is increasing complexity a little bit because you're moving from non-arbitrary to arbitrary relationships between stimuli. Higher complexity then in our hypothetical cognitive training program could be presenting analogical reasoning. So relating relations is higher on our list of complexity. So take the first example, spider is to fly as cat is to dog. So you need to think about the relationships between spider and fly and think about how that maps onto the relationship between cat and dog and then determine, is this the same, is this true or is it false? Are they the same or are they not really the same? So this is just another example of how we could increase the levels of complexity, and then each screen you could be presented with 4 different examples of the relations between the stimuli. We could incorporate flexibility also. So when you incorporate flexibility, the contingencies of reinforcement and corrective feedback can be reversed. So initially, you might ask people to say, if they're presented with 2 the same shapes, to correctly identify them as the same. But then you might ask them to flip their responses, and in the next set of trials, if they're presented with 2 the same shapes, they need to say that they're different, that they're not the same. So really, when you think about flexibility, you're trying to get people to flip their way of thinking or think the opposite way, the opposite to what they would typically try to think. And incorporating this flexibility is really important for those core executive functions, so that idea of cognitive flexibility. Here's the paper that brings all of those ideas together. So it's a discussion and review paper that was published last year, and it expands on all of the concepts that I've just mentioned there, and really at the end, very clearly, step by step, identifies how a behaviour analyst might put together an intervention like this relational training intervention, aimed at targeting those core executive functions for older adults. We did do a brief pilot study, but I'll talk about that again in a couple of moments. And just for those as well, for those BCBAs on the call here, there's some of the behaviour change procedures that have been identified within that paper. Okay, I'm just going to check in on my chat and make sure. Okay, I think everybody's okay. So far, so good. If anybody does have any questions, you can let me know at this point. Actually, I might give you an opportunity. I'll give you a minute. If anybody has any questions, if you just want to type them into the chat there now, just before I move on to the next part of the talk. And actually, even with our delay at the beginning, we're on track, so that's good.
Great, thanks, Michelle. Just as others are writing their questions there, a couple of questions that came in earlier that you might want to address. So from Eugene, he asked, when you say education, do you mean strictly formal education for mental stimulation, which lowers the probability of dementia? What if one does not go through formal education but is mentally stimulated through a different form of education?
That's actually such an excellent question. So the literature does differentiate between formal education, as in attending school or that formal kind of education, and then just differentiates between what they call occupational attainment or other kinds of mental stimulation. So, like let's say 20, 30, 40 years ago, it would be quite common for people not to, maybe to leave school at 14, 15, 16, and start working. In those instances, the idea is that the non-formal education or engaging in lots of mental stimulation through whether it be your occupational attainment or other kinds of mental stimulation, that could compensate for education. But what the literature has identified is that education is still really important. So, really they've called for an identification of this in policy going forward to try to encourage or ensure that all young people have access to education, kind of up to post-leaving cert level at the very least. But yeah, and that's why I was really interested in this as well when I was doing that work on the reviews on cognitive training and mental stimulation, because I work with older adults. So there's no point in me saying to somebody, who comes to me at the age of 65 or 65 saying, oh, you should have stayed in school longer. That's not helpful at all. Well, what can we do now? So now what you can do is engage in mental stimulation as much as possible, and that can compensate for any lower level of education earlier on. I hope that.
Great. No, thank you so much, Michelle. That's an excellent answer. I'm sure that clarified everything for Eugene. Another question by Dr. Sarah. She said, sorry, do you mind muting Michelle just while I'm...
Yeah,
that's perfect. Thank you so much. So Dr. Sarah says, I know a big struggle for behaviour analysts working with ageing populations can be funding. So at least in the USA, there are really limited funding sources for this work. Are there any suggestions on how to overcome this barrier to this really important work? And of course, you're speaking about all the research you've completed. So I don't know what your experience is in Ireland, and if anyone in the UAE in particular wants to share any knowledge that they may have in terms of obtaining funding for this type of work, please do feel free to share in the chat. But yeah, Michelle, if you just want to take that point.
Yeah, thanks. And that's such a great question as well, Dr. Sarah. And that is something I am just unfunded for so long. And I find this challenge time and time again. This is, I suppose, one of the reasons, or one of the ways that I ended up writing that paper in 2020, trying to bring some kind of unity between the behavioural perspective and the cognitive perspective, because it's so difficult to get funded when you're trying to target issues of ageing and you're coming at it from a different point of view that's not neuroscience and not cognitive psychology. It can be really difficult. So it's trying to look at things from a different point of view, trying to change our language, trying to change how we envision the work that we do to try to get that funding. But my only suggestion, saying this when I'm unfunded myself, my only suggestion is to try to look at other ways, to try to look at other avenues and other ways in, maybe adapt. I'll talk in a second, I'm going to talk about cognitive rehabilitation, which is predominantly done by clinical psychologists or health psychologists, but that's so applicable to behaviour analysis. And actually, I did get some funding for the study that I done with that, but it was all about changing my language and saying, okay, I'm not going to say that this is an ABA intervention. I'll call it a cognitive rehabilitative intervention. But that's probably my best advice. It's really maybe trying to establish a name in something by changing our language, and then slowly you can start to bring it back and start to identify all of the ways in which ABA is applicable, which is the route I'm aiming to go on at the moment.
Yeah, so it's a marketing issue, really, isn't it? A marketing and branding issue.
Yeah, anybody actually knows anything good at marketing.
Yeah, I have one more question for you, Michelle, if you don't mind just muting again, just because we're getting feedback. But yeah, just one question here from Raymond, and this is more of a specific question, but he'd like to hear your thoughts around moving from arbitrary to non-arbitrary and or vice versa with someone who has the ability to engage in these processes, but struggles to articulate, maybe in an environment where they are not comfortable socially engaging. So that's Raymond's question. So thank you, Raymond, for your question.
Thanks, Raymond, for that question. So I'm wondering, do you mean during the intervention? So I don't know if I'm answering your question specifically, but what we would do with people who have the ability to engage in these processes, but during the intervention session, if they're not able to properly articulate, we would ask people, we put in an errorless learning strategy and just say, look, if you're not sure in any way, don't do anything and we will come in and we will help you through it. So for the intervention part of it, it's a lot of prompting. So we would really heavily prompt people to get them through the program. And then we would expect, particularly if an individual is experiencing cognitive decline or dementia, which is the population that we did this intervention with, we would expect lower levels of fluency and proficiency as our pass criteria. So I'm not sure if that actually answers your question. Maybe if you wanted to expand on that a little bit more, or send me an email, I'll give you my my email address at the end. Everybody can have access to that. So if you wanted to pick back up on that point, I'd be happy to pick back up on that again. Okay. Can we learn autism relationship responding based on this strategy? Again, Mohammed, I'm not 100% sure what exactly you mean by that, but definitely the strategy is applicable to autism populations. And there's a couple of references right at the end in the resources section, and some of them point to using this kind of strategy with individuals with autism, and it's been shown to be really helpful to help to improve derived relational responding, even things like teaching derived man. It's very helpful with the autism population. So I would encourage people to have a look at those publications in arbitrarily applicable relational responding also. Thank you, Michelle, for putting up my email address there. So just in case I didn't address that question appropriately, Raymond, or Mohammed, you're absolutely free to, please do email me. I'd be happy to hear from you. Okay, so then moving on to the next part of the talk, so interventions at each stage of dementia. And here we're thinking about improving brain health and focusing on this idea of brain plasticity. So often I get asked the question, well, is this important? You know, if a person is already at the point of receiving, they've already gotten their diagnosis of dementia, how important is it to continue to focus on brain health? And the answer is yes, it is very important. Numerous studies have shown that the brain retains plasticity even after a dementia diagnosis. So I suppose what you need to think about is if there's a disease, for example, Alzheimer's disease, that's causing changes to the brain, it will be causing changes in certain parts of the brain, but not in the entire brain. So there are areas of the brain that have retained functioning and retained plasticity that are not being affected by the disease. And it's those areas of the brain that we need to continue to work with to try to improve performance and to try to help people to maybe compensate for areas of loss. It's important to promote as much engagement as possible. So there's evidence to suggest that this can actually slow the rate of decline in some instances, or it can maintain the current level of functioning for a longer period of time. And this is why it's very important. Early diagnosis is crucial, because with early diagnosis, there's more you can do to slow the progression from that point. And these kinds of interventions, it is important to say, are best used in conjunction with the pharmacological interventions, so the dementia medications. Also, when we're thinking about brain health here, I want you to think about not only cognitive functioning as being an important outcome, but quality of life is such an important outcome also. So these are the interventions around brain health that will focus both on cognitive function, but also very importantly on quality of life. Okay. So mild cognitive impairment for early stage dementia, what can behaviour analysis contribute? So I mentioned earlier cognitive rehabilitation, and this is an area that has been, it's an evidence-based intervention for people with early stage dementia or for mild cognitive impairment. So mild cognitive impairment is where an individual is experiencing cognitive decline, but it hasn't quite reached threshold for a dementia diagnosis. But somebody with MCI is at greater risk of developing dementia. So cognitive rehabilitation then is a one-to-one intervention, and it promotes independence and well-being, working on the person's personally relevant goals. The aim of this sort of intervention is to restore function in certain areas of loss, so maybe trying to target areas that people feel that they're doing worse at because of their diagnosis, and to compensate for areas of loss. So these compensatory strategies could be used. So for example, if somebody's memory performance is not what it used to be, they might use memory aids to help to compensate for that loss. and then modification of the environment to help to improve outcomes overall. Existing cognitive rehabilitation research evidence. So as I have said previously, cognitive rehabilitation is generally implemented by clinical psychologists or health psychologists and not often by behaviour analysts. I'm not aware of anybody else, any other behaviour analysts apart from myself, that implement these kinds of interventions. So I would be really happy to hear if anybody else knows of anyone doing this kind of work. The single case studies and randomized controlled trials of this intervention have shown significant improvements in areas like cognitive function, quality of life, and have shown changes in brain activation in fMRI studies. The research
Sorry, Michelle. There's just a little bit of static on your audio. I don't know, perhaps you were leaning on the microphone or something, just so you were conscious of it.
I actually think what that is I'm presenting in a cabin with a roof and it started to rain. So,
as you said, any issue we were going to face, we're going to face it. So yeah, we can't stop it raining. So keep going.
I lean in a little bit closer to the computer and I'll raise my voice a little bit more. Hopefully the rain doesn't get too bad or too much worse.
Thanks, guys.
Okay. So the work that we did around the study phases, as I go through it, you'll start to be able to see how behavioural it actually is. The pre-intervention assessments and follow-up assessments that we conducted, they were cognitive tests, so I did have training in conducting cognitive tests to assist with these. And I worked with the memory clinic in St James's Hospital to implement this intervention. At the next point then, the second phase was goal identification, which was really just working with people on identifying what goals they wanted to work on. So what were the kinds of things that they wanted to improve upon within their lives. Then we started to get into the more behavioural stuff, so looking at implementing a behavioural design, looking at measuring baseline performance, and then the intervention and measuring outcomes as well. The kinds of goals that people would identify within cognitive rehabilitation would be things like, so for example, one lady had a number of grandchildren and she knew all of their names, but she was starting to get them a little bit mixed up, so maybe she might call the wrong child the wrong name. Another individual that I worked with for a number recall, he prided himself in remembering, all of the family's phone numbers, and he was beginning to forget these, or he had forgotten his PIN number for his bank card. Another individual wanted to work on using memory aids to compensate for her memory difficulties, and somebody else wanted to use things like using a mobile phone or using a sat-nav, kind of technology sorts of interventions. Now I apologise for this terrible slide, but within when developing the interventions, I cannot tell you how helpful it was for me to have had my behavioural training. So to be able to incorporate these incredible behaviour change procedures within this intervention was actually so essential to the effectiveness and the success of the intervention. And this was published in a cognitive journal, so the terminology did have to be changed a little bit in some ways. I mean, when you say prompting, there's no other way to say prompting. So sometimes it needed to be changed and sometimes not. So this I put in a table into the paper that just describes the kinds of interventions that were developed. So if I just want to draw people's attention to the first two, so the memory aids intervention and using the phone intervention. So for the memory aids one, for example, I said at random intervals during the intervention session, the participant was asked the time. So basically given prompts at random intervals during the intervention session. So I'll just open up the chat box there. So yeah, thanks, Maeve. Yeah, poor me, who was all going on today. So if we were to say that we presented something at random intervals, from a behavioural point of view, what's another way that we could describe that? So when we're talking about maybe schedules of reinforcement, we wouldn't say random intervals. What would we say instead? Yes, yeah, variable intervals, perfect. Yeah, so that's exactly what I was thinking. Yeah, so for me, I knew it was variable intervals, but if I put that in there, it might have sort of lost my audience for any individuals who did not have behavioural training. For the using the phone intervention, I said the target, this is an easier one. The target activity was divided into 5 steps. So what would we say, instead of just saying it was divided into 5 steps, how would we as behaviour analysts describe that? Yeah, task analysis. Exactly, yeah. So more people, yeah, loads of people getting on with that. Yeah, so it was a task analysis. But, you know, it was necessary to change the language a little bit around that to help the flow of information for the different journal types. I'm not going to go into any more of those, but that paper is there if anybody's interested in looking at exactly what the interventions looked like, and I've identified some of the behaviour change procedures then on the right-hand side to help to align the two. Yeah, thanks so much to everybody for those responses and for the interaction. So another quick question then, what design did we select for this study? So having a look at our graph, what behavioural design did we select for determining our intervention effect? Yeah, multiple baseline design, yeah. So we used a multiple baseline design to help to kind of to figure out basically across goals for each participant. We used the multiple baseline design to help to determine the results. So we also, you know, to evaluate the intervention effects, we looked at the within and between condition analysis, and we examined level trend and stability, of data. We assessed for stability using a stability envelope, and we looked also at the percentage of non-overlapping data. So, I mean, people can see there upon a quick glance, but in general, after doing the full visual analysis, we did demonstrate a causal relationship between the intervention and the outcomes. So even though this was published in a cognitive journal, it was very much, this kind of analysis is very much accepted, which it was appreciated, certainly from my point of view. And this just shows, how people may be able, how you can think about how to apply the skills that we have in a slightly different way in developing interventions to help people to overcome memory problems. Interestingly as well, with those cognitive assessments and with that assistance from the memory clinic, we examined the impact on people's cognitive function. And we did find really impressive improvements on standardized memory and cognitive function tests. So anybody that works with older people with dementia, you'll understand that generally over time you will expect to see a worsening of scores over time. So it is a neurodegenerative disease, so over time performance will tend to worsen. If you can maintain a level of performance over time, that's fantastic. If you can see an improvement in performance, that's even better. And we did see an improvement in performance, particularly for individuals who had higher baseline cognitive function levels. So this was an important point because this really underlines the importance of, again, early identification and early diagnosis. If an individual is diagnosed earlier on, we tend to see better, a more effective outcome for these kinds of interventions with individuals who have a higher baseline cognitive function early on. So really higher levels of efficacy for individuals who have an early diagnosis and who are earlier in the disease course. And that's a really important point. Particularly, I think, for this kind of intervention, it's important to note because it's not an intervention that's suitable for people who are in the more moderate to later stages because they would not really be able to engage with it at the level that they would need to engage with it. Here's a couple of quotes from people. We did a qualitative analysis to supplement the quantitative analysis in that study. And these are some of the quotes that came out from the research. So really highly reinforcing for me, particularly to do this kind of work with people. The quotes here show how impactful this can be from an individual perspective for people's lives. So very, very rewarding, very reinforcing work. And that's the paper there if anybody is interested in reading up on it. Very briefly then, we did also run a pilot study of computerized cognitive training with people with early stage dementia. And this intervention was modelled on the paper that I presented to you earlier around the RFT type intervention and using computer technology to present that RFT-based intervention. This is a pilot study. It's unpublished. It's an unpublished dissertation that Katie Smith from Trinity and myself worked on. And this is a multi-component pre-post intervention, single subject design. We had 3 participants with early stage dementia, and each of the participants went through an 8-week computerized training in relational responding based on this MDML model. And we found improvements in cognitive flexibility, in cognitive function. And the findings of this study support the findings of a previous study that looked at an Alzheimer's population, but honestly, both studies definitely could have been designed better. They were very preliminary, but it does give people maybe an idea or a nod in the right direction of where this kind of research could go, looking at cognitive training for people with early stage dementia. So certainly further research is required there. Okay, so what about moderate stage dementia then? What are the kinds of interventions that behaviour analysts could incorporate for moderate stage dementia to improve engagement and continue to focus on that idea of cognitive reserve? This is not research that I've done myself, but it's a study that I really love by Brentska et al., conducted in 2008. And this study was conducted in response to findings that people with dementia in nursing homes often have low levels of activity engagement. And we know from years of research literature that very low levels of engagement is not good for cognitive function. If you want people to remain engaged, you have to try to encourage that engagement. If an individual is in a very deprived kind of a setting, so social deprivation, very low levels of engagement and low levels of cognitive engagement, sometimes you can see the rate of decline for those individuals increase, or they can worsen quicker than maybe they might have otherwise. So the aim of this study was to increase activity engagement in 6 people with dementia. At baseline, they just told people there's activities in the room by the elevator. The intervention, the other beauty about this study is it's so simple. So for the intervention, if the general prompt that was provided there was not effective, there was a descriptive prompt, which just gave a little bit more detail. They provided a specific description of activities that were available, and they modeled to the individual how to engage in those activities. And then they provided praise contingent on engagement. Something very simple like this kind of intervention can actually have an important effect. Here's some of the outcomes from that study. So increases in presence and engagement. So presence in the activity room and then engagement with the actual activities themselves. Identify the design. Anybody else? So here, let's identify the design of this study as well, looking at the graph. Yeah, thanks, Daisy Linda. Yeah, ABAB or reversal design. Yeah, perfect. While this is just a couple of dots on a page, I can't stress enough how important this kind of intervention is, particularly for nursing home and care settings. Time and time again, I hear reports, just anecdotal reports, of very low levels of activity engagement across nursing homes in Ireland, and I'm not sure if it's the same in other countries. But, it's absolutely all coming from the best place. It's like the person doesn't want to, and that's completely fine. Obviously, people they can choose if they don't want to engage in an activity. However, if they're not engaging in the activity because due to their cognitive decline or dementia, they don't really understand what they're being asked to do, they will tend to withdraw a little bit more. They may have lower levels of confidence, and this withdrawal in the long run actually serves to only increase the level of decline or decrease the level of functioning or independence that the person can experience. So these kinds of interventions are really crucial across care settings. And even for individuals who are caring for loved ones at home who may be experiencing cognitive decline, trying to figure out ways to encourage them to engage in activities or social activities a little bit more is really important. I just see a comment popping up there on the chat. Yeah, part of it can be due to engagement level of the person, but also due to staff training to promote engagement. That's such an excellent point, Hannah, because it really is, sometimes it's not, as I said, it's never coming from a bad place. It's just that the staff training, the staff may not have that training to be able to promote engagement, or, you know, the staff maybe haven't been taught these different strategies to help them to promote engagement. This particular publication is lovely because it identifies how easy that could be. So how behaviour analysts maybe could work with staff and conduct staff training within these care settings to help to promote increased levels of engagement. So that could be where it could be most beneficial. Maybe it could be around behaviour analysts contacting care settings and maybe seeing if they would be interested in some kind of staff training or something like that. And that's that paper there. So the later stages of dementia then. So what about functional assessment and functional communication training? So when we think about the later stages of dementia and this idea of what's most effective and what's most required, typically in the behavioural research we will find that there will be a focus on the behavioural and psychological symptoms of dementia. And these behavioural and psychological symptoms of dementia are quite common, particularly in the later stages. But typically, what has been found in the literature time and time again is functional analysis-based interventions generally result in a significant improvement in outcomes based on PTSD. And, you know, obviously us as behaviour analysts, we understand that how important a function-based intervention is, particularly if it's different kinds of difficult behaviours. So the symptoms of PTSD, just to mention, include depressive symptoms, anxiety, apathy, sleep problems, irritability, psychosis, wandering, elation, agitation, and sometimes some kinds of verbal or physical aggression. So Dreyer et al. Looked at a systematic review of RCTs of both pharmacological and non-pharmacological interventions and identified the significant improvement with functional analysis-based intervention. If you just have a quick look here at the different kinds of non-pharmacological approaches that can be used with people with in the later stages of dementia, and if we just focus on the non-pharmacological ones, at the top here on the left-hand side of the screen. So we see the functional analysis-based interventions here at the top, and then things like psychological therapy, music therapy, cognitive stimulation, and exercise. In that systematic review, the authors identified 12 studies, SA-based studies, and over on the right-hand side, the grade, that refers to the quality of the studies. So a moderate level of quality in comparison to, you know, another moderate for psychological therapy, and then lower, very low for the other kinds of interventions. And you can see here, you know, the functional analysis-based interventions and the music therapy ones were the only two that showed significant improvement. But for the music therapy, the grade of evidence was much lower and much fewer participants as well. So over 1,500 participants for the FA-based interventions compared to 397 for the music therapy. So in terms of non-pharmacological approaches to working with people in the later stages of dementia, FA-based interventions far outweigh, in terms of evidence, other kinds of non-pharmacological interventions. So again, as behaviour analysts, if we're going to focus our attention in this space, it's socially significant, it's important, and it's evidence-based. So the evidence is there to show us that this is an effective route or an effective intervention strategy to take with this kind of population. There's another great Cochrane review. I just wanted to put that up there to bring people's attention to it. This Esme Monis-Cook wrote this Cochrane review, and it's looking at a review of lots of different kinds of FA-based interventions for challenging behaviour in dementia. And, you know, I think the paper is like 150 pages long or something, so it goes into each of them in a lot of detail. And really is very informative when thinking about the kinds of interventions that you could develop for behaviours for later stage dementia. Okay, so I want to engage in another activity then. So let's have a think about an FA and SCT example. So let's say, for example, you as a behaviour analyst have been referred a case. The behaviour of concern was physical aggression, and a note on the file was that the individual's verbal communication skills, due to their dementia, were declining. So they weren't really able to verbally communicate anymore. Let's say you conducted a functional assessment and identified an escape function specific to meal times. So I would like to see if people want to take a couple of minutes. We have plenty of time here. I thought that it was going to take me longer due to the delay at the beginning, so I have kind of flown through the content. So we have a little bit of time to spend on this. I would be really interested to see what are the kinds of interventions that people might come up with to address this behaviour of concern. Yeah, so Kelly, choice for meals offered at mealtimes, and Tara said giving choice as well. Khalid, training on asking for a break. Yeah, that's a really good point as well. So even if you wanted to expand on that a little bit more, so training on asking what would that training maybe look like? Cormac says antecedent manipulations. Yeah, so having a look at the antecedents to the behaviour. Again, Cormac, if you wanted to expand on that a little bit more, so what specifically do you mean? Could the antecedent manipulations look like? Shauna, a break card to leave. Exactly, that's a really good suggestion as well. So instead of, the individual does not want to be there, so maybe give them another way to communicate if their verbal communication skills are declining. Yeah, shower, taking a medicine. We'll try to just, as opposed to a pharmacological approach, we'll try to just focus on the non-pharmacological, so just what kind of intervention, not medicine-based, we could look at. Yeah, a break card to lower the response effort. Conduct a preference assessment. Yeah, so Lauren, that's a good point as well. So I'm interested to hear you expand a little bit more on that too. So in terms of conducting a preference assessment, what would the goal of conducting the preference assessment be? And are you talking about preference assessment just in general to identify reinforcers, or preference assessment in terms of specifically around meals? Kelly has said, can visuals be used for offering choice, for asking for something else? Yes, so that's a really good idea as well, Kelly. So this is a good point, because if the individual's verbal communication skills are beginning to decline, the individual may not have the capacity to read or to be able to speak. So you need to think about what kind of visuals can be used for people in the later stages of dementia if they're not able to read anymore, or if their verbal communication skills are declining. Picture exchange can be really helpful. So using visuals, perhaps a choice board, as Kelly has suggested, is a good idea. And from Mohammed, give them cards for choice of what they need. Exactly. So lots of people agreeing that choice would be important in this instance, which, I fully agree with. Requesting to reduce the quantity. That's actually a great suggestion as well. So that point is about really trying to figure out or identify what the issue is with the meal. So, I suppose we need to think about the individual still has to eat. So if they refuse every meal, and if they're given an alternative response option, so if they're given a break card, for example, and the meals can be removed for appropriately communicating, well then, if the meals are always removed, then that's problematic in that the person may not be able to eat. But if you request to maybe reduce the quantity, or try to figure out exactly what is it about the meals that is problematic. So maybe the meals might be too cold. Maybe the person has always enjoyed their meals being very hot, and maybe that's why that's the issue. So maybe trying to analyse each aspect of the situation, try to analyse exactly what's happening there. Offer choices, yeah. I've seen a company put drinks into a capsule that look more appetizing, drinks rather than food, from Cormac. That's a great point as well, and there's some really excellent work being done out there around people's plates and making the plates look more appetizing. So sometimes as well, people will know, if you work with older people with dementia, sometimes their swallow can be affected, and lots of their food maybe needs to be liquefied. But if you liquefy somebody's food, it doesn't look very appetizing. So there's actually a website, I must look it up after and I'll send you the link to it if anybody's interested. And there's a website dedicated to helping people to plan plates that look more appetizing even with food that has been liquidized. And that's very important as well. So that's all about manipulating the antecedents to try to change the outcome of the behaviour, absolutely. Sarah says, collaborate with a speech and language therapist to identify an alternative communication modality and make sure to incorporate client choice into the selection. So that's an excellent suggestion as well. And speech and language therapists play a really important role in working with older adults as well who have issues around feeding. So it is definitely, you know, it's important to consult with other individuals in the field, in other areas as well, to try to come up with an appropriate alternative. And choice is so important also, yeah. Shauna says use a break card or combined with a delay to reinforcement, i.e. increasing the amount of time before they can leave. Yes, so this is a good idea, Shauna, for if you're trying to fade back. So if the person consistently asks for a break and then is never getting the meal, so is obviously reinforced for the appropriate communication upon that appropriate communication occurring. This is fine, but we do need to try to work in or try to plan for fading that back a little bit, delaying the reinforcement, so increasing the amount of time before they can leave, or even requiring that the individual eat a certain amount of the food before they can leave. Yeah. Just scrolling down here through all this is brilliant engagement. So thanks for this. So Wendy, choice with seating, meal choices using the visual support. Yeah, great example as well, Wendy. So not just focusing on the choice with the food, but also focusing on the choice of the place that the person eats. So perhaps this person was very particular about always having their meal sitting at the kitchen table. And maybe in the setting that they're in now, maybe the meals are being presented to them in bed. Maybe they've never eaten meals in bed before, so maybe that could be a source of the difficulty with the behaviour. So choice is, and you know, across the board people are suggesting that, which is brilliant. So choice is very important. Not just meal choices, but also choices around different aspects of the environment. Differential reinforcement of alternative behaviour, so lots of differential reinforcement suggestions coming in there with breaks, which is a great suggestion as well. So, you know, is there what alternative kind of behaviour or incompatible maybe behaviour could you teach to the individual? Appropriate rejecting response. Yes, exactly. So trying to teach an appropriate alternative response. And Kelly has asked, is there a pattern with specific foods offered that result in physical aggression? Yeah, good point, Kelly, as well. So try to look at the pattern of behaviour with specific foods. So really, this is all about the analysis, looking at the analysis of the behaviour. Is there a specific pattern with specific foods that results in physical aggression? Is there less aggression with some kinds of food and more aggression with other kinds of food? Yeah, baby Linda says food paired choice PA. Yeah, so having so food paired choices, so having increases in choices in the person's selection of food. And Amal now and next, with next being a more preferred activity. So yeah, absolutely, you could even use the Premack principle here. Visual presentations of now and next so that people understand exactly what's coming next. Yeah, you've said, however, this is not a functional strategy, meaning that it does not provide escape as a consequence. But really, I mean, you do make such a good point, and it is important to look at a multifaceted or multi-component kind of an intervention. Tangible, visual cards, make mealtimes more reinforcing. This is a good point from Amber also around making mealtimes in general more reinforcing. So a lot of the work that we do with older people with dementia would be around life story work, and it's important. If anybody who has experience of dementia will know that it's the short-term memory that tends to be impacted or affected first. So the person may not be able to really remember what happened yesterday, but really has a very clear memory of, you know, what the things that they did in their 20s, so what their life looked like when they were children. And this is really nice to incorporate into what we call a life story book for staff who are working with the individual, because it gives staff a sense of who the person is. And this can be incorporated into any situation where there might be some kind of challenging behaviour, and even things like repetitive questioning. So you can have a look at what the individual liked in the past. So what Amber has suggested here is favourite music, a favourite movie, and looking at the times of meals. So looking at the person's personal preferences and looking at the person's reinforcers, whether it be music, and that could have been documented in that life story work. And that's a good way to make the mealtime itself more reinforcing. So just trying to pair up that activity with other preferred reinforcers is a nice strategy. Amy, I did not give the second code for attendance yet. I'm going to give it after this slide. So you didn't miss that. Lauren has said paired stimulus assessments, absolutely, with different food options. And Roberta has said, I'd be interested in information regarding the elders past. What was the food of choice? What was the time when they would normally eat? Did they prefer to eat on their own or in groups? And then I would want to know what is happening during their meals and before. Is there a clear indication that dinner or mealtime is starting? Yeah, exactly. How predictable is the onset of the mealtime? Have we moved the older person from an activity that they wanted to do? Yeah, has there been termination of a preferred activity to move to the mealtime? Do we know that the older person can access waiting in line? Can they carry their tray? It would definitely depend on the functional ability of the individual. You know, some people would obtain meals in their rooms or in their beds, or some might obtain rooms in a shared space. What choices is being offered? So this is still Roberta. Is the food laid out in a way that's appealing? And I think you could go on and on. Yeah, absolutely. So I think that you've made a lot of really relevant points there for consideration. Kelly has also asked, is there a medical consideration? For example, does the person have dental pain? So yeah, that's important also to consider. Are there any other indications that need to be considered? Other people have said, I have heard that plates that have patterns may be off-putting for people with dementia. Yeah, is it better to use a plain coloured plate? Absolutely. So in the more moderate to later stages of dementia, differentiation of different shapes and patterns, and even differentiation of, let's say, a step in the ground, too many mirrors, there are lots of things that can be very disorientating for a person with dementia. So it is much better to have a plain coloured plate. A white plate is preferable, absolutely. If you have a plate with lots of different patterns, the person may get quite confused and not really understand or be able to figure out what's being presented on the plate. So that's a good point also. Hannah says also to remember to take a look at the medications, side effects. Sometimes they can cause loss of appetite. This is really important as well. Nausea, not an intervention, but it's important to take a look at before implementing an intervention. Hannah, that's a great point. It's always important to have a look at all of the other factors that could be contributing to the behaviour before implementing the intervention, and really having a good background knowledge. I mean, any of us who work with clients, we all know how important it is. When our client is referred for a behaviour of concern, the first thing you want to know is, well, tell me everything else. I need to know everything else so that I can really understand the behaviour properly in context. Mohammed, verbal behaviour, like point to what the person wants. Yeah, sometimes this behaviour happens due to the need for more attention or escaping. Yeah, absolutely. So if the individual can't engage in verbal communication like they did previously, can you use gestures? You know, if the person is not engaging even with the picture stimuli, you could use text, but if they're not engaging with text, could you use gestures? That's a good point also. Colour-coded meal types so that the person can choose easily what they prefer to eat. Yep, that's another great suggestion, Baby Linda. Thank you for that one. And Tara says, make the environment more enjoyable with social interaction and music, which is related to a previous point that somebody else made around pairing up reinforcers, understanding what the person enjoys, and how to make the environment more enjoyable. So I think I got all of the comments there. Thank you so much for such really excellent comments and really excellent suggestions, and such great engagement with the question also. I hope that throughout, whether it be at the point of improving a healthy lifestyle to try to contribute to overall brain health and dementia prevention, or whether it's working with people who are just experiencing mild cognitive impairment, right through to working with people who are in the later stages of dementia. I hope that this talk has given you some ideas. Obviously, it's impossible to cover everything. And obviously as well, because this talk it's an ABA focused talk, so I did only focus on relevant aspects to behavioural analysis. But I really hope that it has given everybody some new ideas and some oversight into how, as behavioural analysts, we have such an important contribution to make to older adulthood. There's some of the behaviour change procedures. So in conclusion then, I wanted to just finish up by saying I always use this little picture of the rat with the placard, Save the World with Behaviour Analysis, because the longer I work in the field of behaviour analysis, the more I see how applicable it is to a wide range of issues or concerns in people across, worldwide. It's so applicable, and I suppose particularly, I'm so biased obviously, particularly I think it's so applicable to issues of ageing and older adulthood. I want to spread the word as much as possible about behavioural gerontology and how important it is. I really do think that, and I hope everybody else has taken that from today as well, that it's an interesting and timely and positive approach. So it's trying to think about things slightly differently to maybe how our training, a lot of us would have the majority of our experience maybe in the area of autism or intellectual disabilities, whether it be younger people or adults. But not many would have a lot of experience working with older adults. But the skills that you learn are transferable and they are applicable. And I hope that this talk has given you some inspiration to try to diversify the application of your skills. So it's a really timely and a really positive approach for promoting behaviour change, and behaviour change looking at older adults' brain health, which I think is an area that most behaviour analysts would be like, oh no, that's definitely not us. We couldn't really do the whole brain health thing. But, you absolutely can. Obviously, from an ethical point of view, we all need to make sure that we're working within the limits of our competence. But I think, Clodagh has made a really great point there about communicating to students for many years that the job market will open up. And, yes, we have to practice within our range of competence. But we can always take the opportunity to build our competency in other areas and work under the supervision of somebody else that can help us to build up our competencies in working with older adults. So Clodagh has said there, I've been trying to communicate this to students for many years. The job market will inevitably open up as people expect to maintain their quality of life into older adulthood. I think that's such an excellent point, Clodagh, and it will absolutely open up. So when we start to, and it is all about marketing as well. I think as behaviour analysts, we know historically we're just not good at marketing. Maybe we should all take a marketing course as well as our ABA classes. But we just need to be able to understand how to market ourselves. And Clodagh is right in this job market will inevitably open up as people are living longer, population ageing is happening all across the world, and people are interested in how to maintain and improve their quality of life as they get older. And that's the quality of life for ourselves, our families, our loved ones, and so on. And thinking about the applicability of our skills as behaviour analysts outside of maybe the norm or what's common or what's most commonly observed, thinking about the applicability of our skills outside of that is going to really help to improve the quality of life for other people into older adulthood. Okay, so there's a couple of resources there at the end of the slides. I will just send those on to Michelle and she can share those with you. But just at this point, we've just about 10 minutes left. Does anybody have any questions specific to any of the content? Anybody have any questions or queries that they would like?
Hi, Michelle. I'll start the ball rolling. There was two from earlier that I took note of, if that's okay. So Laura, how do you identify suitable participants with early stage dementia?
That's a great question as well. So personally, I worked with the memory clinic in St James's Hospital. The memory clinics are quite a good point of contact. I'm not sure kind of worldwide what would be comparable, but here at memory clinic, it's where an individual would go to seek a diagnosis. A person would go to their GP first and foremost, and then would usually be referred to a memory clinic. So typically the memory clinic will have access to a range of individuals, and particularly for early diagnosis, people will probably seek out a memory clinic if they're earlier in the disease course, as opposed to just GP care. So the memory clinic, certainly in Ireland, and I think it is actually a similar model in the UK, would be a really good access point to identify participants who are much earlier in the disease course. Also, what we did with the cognitive rehabilitation intervention is we just advertised in communities. So in community-based settings, we just advertised the study that we were running and the kind of intervention. More and more often, there are people who are living in the community who are still like fully functioning, at home with families, and some people maybe even still have jobs when they obtain their diagnosis of early stage dementia. So targeting individuals who are still living in the community, particularly if your intervention is going to be focused on early onset or younger onset, that would be important. It's difficult to get buy-in though, like with so much recruitment, our participant numbers were still quite low. So it's quite challenging, but the memory clinics or just general advertising within the community would be my response to that.
Thank you so much, Michelle. Claudia's there's a few questions coming through. Actually, there's loads of questions coming through. But just to address Eugene's question, because I do think it's a good one. He was like, he really wants to get into this field and how to get started because opportunities are scarce. So you have any tips of how to get started? Thank you.
Yeah, the opportunities are really scarce, and that's a really good point as well. And Eugene, I'd be curious, what part of the world are you in? Michelle, I'm not sure if that information is there, is it? But yeah,
you might pop it in the chat now. Oh, he's in the UAE. It's so hard for you to answer.
It is, yeah. And I suppose maybe I could just talk about from my point of view, the opportunities are quite limited. But it's around trying to identify, if somebody is interested if there's an advertisement out there for somebody working with people, with older adults, maybe just applying for different jobs like that. I think also behaviour analysts would maybe shy away from applying for a job in a memory clinic maybe, or in an institute in neuroscience, or, we might shy away from applying for those kinds of jobs because we might think, well, really, am I going to get that job? What can I offer? But if we start to look at those kinds of job advertisements and start to reframe how we think about what we can offer for those jobs, well, then it's going to be a very different interview process when you're like, well, here's all of the things that I can offer in this position. So maybe it's about identifying opportunities that are not sort of typical to behaviour analysis and trying to get an in that way.
Thanks, Michelle. And then a question from Claudia. Have you, Michelle, presented your work at conferences outside of behaviour analysis, and how has it been received?
Yes, I have at a health psychology conference and then at a couple of the ageing conferences. It has been received very well, but I do have to say that I haven't presented at an ageing conference in a couple of years. If I was to present now, I would be much more confident in no, I'm a behavioural analyst. This is a behavioural perspective. This is the way I'm going to present it. Whereas a couple of years ago, I was still very conscious that I was still trying to establish myself a little bit more in the field. So I was very much adapting my language and adapting how I talked about the interventions much more to suit a cognitive or neuroscience audience. So it was received well, probably because maybe there wasn't as much behavioural stuff in it, but certainly more now. I did present at a health conference recently and it was received very well. So I do think it's all about how you sell it, and I certainly will be signing up for some of the more ageing focused conferences, and definitely, we're behaviour analysts, this is what we have to offer, putting that spin on it a bit more.
Absolutely. Thank you so much, Michelle. And there was a question as well from Aoife. What is known about maintenance of skills that are successfully taught to adults with dementia through FCT?
Great question, Aoife. This is one of the points that needs to be considered when running any kind of an intervention with a person with dementia. And this is across the board, across behavioural interventions, SCT type interventions, FA, and also around the cognitive interventions. The maintenance of intervention effect, the length of time for maintenance does not tend to be quite long. And it's something that people should be aware of when they're entering into that intervention, and it's something that we would talk to our participants about. And, that's because of the nature of dementia is that it's neurodegenerative over time. So the maintenance of skills, you would be, some of the cognitive rehabilitation, the CR interventions that I talked about earlier, you can see intervention effects up to maybe 12 weeks, 6 months, and the maintenance effects do tend to drop off after that. But really, people do understand, whether it's the person developing the intervention or the families who are taking part in the interventions, they understand that it's the here and now that's really important for their family and improving quality of life. If you can improve the quality of life and maintain functioning for a person and maintain those intervention effects for 6 weeks or 12 weeks or 3 months, even if it's only for 3 months and nothing further than that, that's still very meaningful. The maintenance of skills, it would tend to drop off, but the quality of life piece tends to remain for longer. So the maintenance in self-reported quality of life would tend to be longer, whereas the skills levels do tend to drop off more. So yeah, that level of maintenance, you would expect it to be shorter, certainly, for working with dementia populations.
Thanks, Michelle. There's so many questions. We've got 3 minutes. Amber says, you talked a lot about early stage and individuals moderately impacted by dementia. What is the potential for positive impact for later stages?
Yeah, that's also a brilliant point. So the potential, it's definitely a little bit more difficult with later stages because there are so many very unique challenges with later stage dementia. The potential for positive impact is still important. It's at the later stages, the impact around maintaining functioning or improving functioning over time, obviously, that's not going to be as relevant, particularly with very later stage. So at very later stage, the positive impact needs to focus on things like quality of life for the individual, and maybe all of the focus just needs to be on quality of life. Like when we talk about social significance, we need to understand from the person's point of view, well, what's important for them, thinking of this from a person-centered and a holistic approach. So certainly the focus of, as you said, positive impact, the focus will change depending on whether you're working with early or late stage, but there still is that potential there for the improvement of quality of life. If an individual is engaging in behaviours, difficult behaviours, because they're distressed or, if they're engaging in repetitive questioning due to anxiety about not being able to predict what's happening next, or because of a lower level of understanding of their environment or the environmental contingencies are all off, that can really significantly impact on the quality of life of an individual at the later stage. So for behaviour analysts, it would be about trying to improve the environment that the person is in to promote better outcomes. But there's still potential for positive impact, but the focus does certainly change.